Thanks everyone for calling in today. My name is David Fagenbaum. I'm the co-founder and executive director of the Castleman Disease Collaborative Network, and most importantly, I'm also a Castleman disease patient. Before I start out the webinar today, I did want to just highlight how incredible I thought World Castleman Disease Day was. It was so wonderful to see so much enthusiasm and excitement from patients all over the world raising awareness for Castleman disease. So just want to start out by just thanking so many of you for getting the word out on July 23rd about World Castleman Disease Day, and I think it was a really, really wonderful day. So for the webinar today, as I said, we're for some reason having some technical audio issues. So I'm hoping that Frits will be able to join on momentarily. But in the time where we're waiting for him, I'm going to go ahead and kick things off with just a little bit about the CDCN and opportunities for you all Castleman's patients to get involved with this fight against Castleman disease. And hopefully you guys can follow along with the screen. So just briefly about the Castleman Disease Collaborative Network. The CDCN is an international network of patients, loved ones, physicians, and researchers that are all dedicated to curing Castleman disease. The way we do that is by bringing everyone together to set priorities for research and then relentlessly working to perform those research studies to hopefully cure this disease. As I said, I'm a Castleman disease patient, and one of the reasons I think we've been successful thus far with the CDCN is because we've had so many incredible patients from all over the world contribute samples and data financially and in so many other ways this fight to cure the disease. So if you're following along on the screen, you'll see that I titled the slide, "The Cure is Within Us." And what I'm trying to get across here is that Castleman disease is very poorly understood. We don't understand what causes the immune system to shut down and attack your vital organs and to do what it does. We don't understand the cause. We really don't understand the mechanisms very well. But the reality is that every one of us with Castleman disease, we all have that information, the clues, the evidence within each of us. So our blood samples, our lymph node samples, any sort of tissue that we can provide, that is where this information will come from to cure this disease. And I remember seeing a post recently from a fellow Castleman's patient who said that his greatest hope for a cure is the CDCN, and as Castleman's patients, our greatest hope for a cure is the CDCN. And I responded by saying I 100% agree with that, but I also would say that the greatest hope the CDCN has for finding a cure are patients, and there's no way that we can do that without support from the entire community. And so I wanted to take just a few minutes today to highlight some of the ways that you all can contribute. Just, sorry, real quick, are there folks that are on the call that can hear audio?
Yes. Okay,
good. So at least some people were okay. Yeah. Sorry about that. Yeah. For some reason, there's some real audio issues this morning. So the first action item for us, our opportunity to fight back against this disease is to share your Castleman disease data. Something that many of you guys that are aware of the CDCN know about is what we call the Accelerate Registry. Accelerate is the largest study that's ever been done of Castleman. We have, oh, and sorry, if you are, if everyone's able to just mute their computers and their phones, that would be great. Let me see if I can do that. Okay. So the Accelerate Registry is by far our largest study, the largest study that's ever been done for Castleman's. Currently, there are about 200 patients that have enrolled. It takes about 15 minutes for a Castleman's patient to go online to cdcn.org/accelerate and to enroll into the study. And the reason it's so important is that when you do enroll as a patient, you are then enabling our team here at UPenn and the CDCN to request your medical records, and then we have a team that goes line by line through every single page of every record, even thousands of pages, to pull out all of the key data. And we're doing that constantly. We have, as I said, about 200 patients in, and we're collecting data and extracting data constantly. It is by far the greatest opportunity we have to better understand Castleman disease, to learn from all of us, and to learn, to gain clues from all of the information and data that exists in each of our medical records. So you can see the link here. We'll send this out after the call. And you can also email us if you have any questions at all. Again, it'll take about 15 minutes for you to sign up, and then our team here at Penn will go through all of your records and do all of the hard work after that. Geez, now I just got a message saying that we dropped out. I can hear some audio. Okay. Thank you guys for the help with the audio. I'm so sorry. I'm not sure why we're having these issues today. Okay, so the first thing is contributing your data to research, and it's something that that all of us can do, and hopefully we can really learn from one another's cases. The next thing is to contribute samples if you are currently in the hospital or if you're having a flare. Again, the clues to this disease are within each of us. They're in our blood, they're in our lymph node, and we are performing the studies through the CDCN to better understand how this disease works. So if you are in the hospital or if you are experiencing an increased number of symptoms and laboratory abnormalities, then please contact us. You can see a link here to express your interest. You can see a phone number and an email address. If you have a lymph node surgery plan to excise it, please let us know. We'd love to be able to talk to you about it and see if there's a way that, or see if you're interested in contributing some of that tissue for research. Next is to donate funds for research. So all this research we're doing is unfortunately very expensive, and we are very fortunate to have a lot of patients that have contributed towards this and been able to do a lot of really exciting research. And you can see listed here the links to donate, and also an email address you can reach out to if you have any questions. One thing that's unique about the CDCN is that the research that we fund is based on what our global community prioritizes. So we have a huge network of physicians and researchers around the world that prioritize our studies, and so every dollar can go to the most high impact research. The next is to learn about the Warrior Program. So you have an opportunity to join. On Facebook, you see a lot of people talk about Castleman Warriors. The Castleman Warriors is actually a program. So we have there's about 20 to 30 Castleman disease patients who have signed up to become Castleman Warriors. And Castleman Warriors, we have a monthly phone call to discuss our individual cases, what we're going through, and also opportunities to fight back against Castleman disease. Mileva Rapaski is the incredible director of that program and helps to make sure that patients that are part of the Castleman Warrior Program are supported and also do their part to fight back. And so you can see here there's a link to sign up. You can also email Mileva if you have any questions about the program. Next is to connect with other patients in the community. There's a link here to make sure that you're signed up as a Castleman disease patient so we can provide all the support and resources that we have to you. And then lastly is our patient summit coming up on September 21st in Philadelphia. This will be the third year we're holding it in Philadelphia. It'll be our fourth year of holding an annual Castleman disease patient and loved one summit. Currently, we have 100 Castleman disease patients and loved ones that are registered for the summit. It's the most we've had sign up thus far. There's still some room if you guys are interested in signing up, but obviously we're getting very close to the actual date. You can see the link here for more information, and of course, please, as always, feel free to email info@castlemannetwork.org or call the CDCN cell phone with any questions that you have. Before I turn it over to Dr. Van Rhee, any questions or comments about any of the opportunities to fight back? All right, I'm going to pass this presenter role over to Dr. Van Rhee, and Frits will be able to take it further. And while I'm passing it over to him now, I'll just mention that Frits and I started the CDCN back in 2012, and it has been just such a pleasure and honor to work with Frits to try to advance research.
So that's why I'm particularly interested in this.
Frits, I'm passing over the presenter role, so hopefully you should be able to accept that.
Thank you, Mike. favorite spots with you so that I could put my coffee on the desk.
Oh,
Thank you.
I don't even drink coffee yet.
Question, where did my coffee go? I put it up here.
Oh.
Frits, are you able to hear us and able to accept the presenter role?
State flash.
Oh, wait.
Frits is now accepted it. Let's see. And for folks that are on the call, there's a bit of background noise. So if you're on the call, please be sure to mute your line or mute your computer so that everyone can hear Dr. Van Rhee well.
All right, David. Can everybody hear me now?
I can hear you, Frits.
Okay. Am I loud enough?
Sounds good to me.
Okay. All right. Well, thank you very much for the excellent introduction. What I'm going to be doing is giving a brief overview of Castleman's disease, and then specifically address some of the issues which were submitted by the patients. Issues dealing with treatment, side effects, pregnancy, etc. And obviously symptom management, the risk of Castleman's disease transforming to another disease has been a concern. So to start with just a brief overview, Castleman's disease is really a variety of diseases which sometimes look similar under the microscope. There are three main varieties. There's the unicentric disease, which means that you have enlargement in one lymph node. Then there is what we call idiopathic multicentric Castleman's disease, which means that we do not fully understand the cause of the disease. And there's obviously an area of active research. And there's also what we call HHV8-associated multicentric Castleman disease. These are people infected with HHV8 virus, that's human herpes virus type A, which is active and dividing in the patient and giving rise to the Castleman's disease. So overall, Castleman's disease is a rare disease. It's also actually quite complicated. So in general terms, it's important to seek expert advice and at least get input from a physician who's got experience with Castleman's disease. So unicentric disease is disease which grows in one area, one lymph node area. Here you can see a patient with a large mass in the abdomen. And this patient had symptoms because the mass was very big. So often the diagnosis is actually incidental because the patient may feel a lump in the neck or in the groin, or some x-rays are done for another reason and a mass is being found. The unicentric disease is slightly more common in females, and it's usually in younger patients. So the light blue bars here are the unicentric disease. Trying to advance here. Sorry, I'm trying to advance the slides.
Frits, we can just see your screen with about 20 slides up. We don't see the specific slide itself.
Oh, okay.
Like the zoomed in version.
I have it here on slideshow.
It's projecting this.
Yeah, that's good. Okay. I think it's projecting the wrong screen. I've got two screens here. Is this better?
No.
No, now we see a just your desktop. Yeah, we see the desktop with with your email and with the minimized. Yeah, that we see that screen.
So yeah, let me at least talk. Katie is trying to fix it here. So in general terms, what you do for unicentric Castleman's disease is surgery. So you try to remove all the affected lymph nodes completely, and that's curative in most patients. Well over 90% of patients, it can be cured just by surgery. If the patient is entirely asymptomatic and the disease cannot be resected, then then you could just observe, because this unicentric disease may not enlarge or may get larger very slowly. Other options are to treat with a drug called rituximab to try to shrink the disease and make it resectable. And sometimes one can do what is called embolization, which is cutting off the blood supply to the Castleman's disease. And finally, an option is to irradiate it. Can you now see the slides better?
Yes, we can.
Okay, all right. So in general terms, the outcome of unicentric disease is good, although there are a few more difficult to treat patients for which there are other options if necessary. So multicentric disease is characterized by lymph nodes at multiple sites. And the lymph nodes release or they make something which we call cytokines, which have effects on other organs in the body. And patients get night sweats, fevers, and they can feel unwell. So one of the cytokines is IL-6, but there are probably other cytokines as well which are important. They stimulate the growth of the lymph nodes and make the lymph nodes large. You can get increased formation of blood vessels, leaky blood vessels, and patients can get swelling of their extremities, swelling of the belly, fluid accumulation in the chest. Then another effect of the interleukin-6 is that it can dysregulate your immune system, and you can make autoantibodies. That means that you make antibodies which react with your own organs. A common one is that you get breakdown of red cells. And finally, these cytokines are the things that make you sick. It's like having a severe flu. You get night sweats, fevers, poor appetite, and patients feel generally unwell, and the symptoms sort of don't go away. Sometimes the clinical course is waxing and waning, so it gets better and gets worse. In others, it's more or less steady and ongoing. And there are also patients who gradually get worse and worse and can get very sick. Typically, when we do the lab tests, we find that patients are anemic. The main protein in the blood is low. The main protein is called albumin, and that contributes to the leakiness of the blood vessels and add to fluid accumulation. And typically, a marker of an inflammatory response called C-reactive protein or CRP is high. So usually these symptoms and these abnormal lab values go hand in hand. So multicentric disease is more common in males. The average age is 50. We tend to see quite a few younger patients, and it's my impression that sometimes the younger patients are actually sicker than the older patients. There are various therapies for multicentric Castleman's disease. Steroids are often used to dampen down the inflammatory response. The problem with the steroids is that you need to give high doses, and when you taper them down, the Castleman's disease often flares up again. Then there are antibodies which target the interleukin-6 molecules, and there are two of them. One is called Sylvant or siltuximab, and the other one is called tocilizumab or Actemra. They both work equally well. And there's an old antibody used for the treatment of lymphoma and other disorders which can shrink the lymph nodes, and that's called rituximab. And some patients may require what we call real chemotherapy. That means chemotherapy which makes your hair fall out and which can give rise to other side effects. None of these treatments is ideal. The interleukin-6 antibodies really require very long-term administration, and we think that therapy probably has to be lifelong. So what do you do for the multicentric form of the Castleman's disease? Usually the first line of therapy is to give either the anti-IL-6 antibodies or the rituximab drug if you have more mild disease. If you have severe disease, you start with the anti-IL-6 antibodies. And patients who are severely ill sometimes require combination chemotherapy. There are two reasons for resorting to chemotherapy. First of all, it takes time for the antibodies to work. You need to have several doses, and some patients just cannot wait for this response to occur. And there are also other patients in which interleukin-6 may not be the molecule to target. So there's something else driving the disease. And that's been the subject of active research. And I think we have some very interesting data about other molecules which possibly drive the disease, which have been generated by David and his team. So research there is very important. I won't go through all the other options, but if you fail what we call first-line therapy, there are a number of other drugs which can be considered. So there are treatment options beyond the ones that I mentioned. So living with Castleman's disease is really very frightening. Usually when you go on the internet, you read stories that the survival is poor, and even the scientific literature is not always very well informed. So it can be quite a shock to be diagnosed with Castleman's disease, and patients don't know what to expect. Then they go to their local doctor, who usually doesn't know very much about Castleman's disease. And one cannot blame the local doctor because he may only see one Castleman's patient in his whole career. So you're dealing with a rare disease, and which is complicated as well. And then patients often have the feeling that their local doctor is not well informed about this disease. So it's very important to connect with the Castleman's disease community, and also, if possible, to seek out an expert opinion. And there are various physicians around the country who see Castleman's disease. It is also important to realize that most patients, the vast majority, do very well with, in terms of long-term outcome. And one should be positive about the long-term prognosis. But again, it may be important to get somebody involved, a doctor involved, who is familiar with Castleman's disease. So the outcome is good, but at what cost? As I mentioned, some of the treatments needs to be given lifelong, like the antibodies which target interleukin-6. Then there are side effects of treatment. And obviously, this diagnosis creates a lot of stress and anxiety. What will happen in the future? Will I ever feel normal again? Can I work? Can I look after my family? Can I get pregnant? And what's going to happen to this Castleman's disease? Can I get a cancer as a result of it? So there are a lot of questions which rise when you get a diagnosis of Castleman's disease. I'm now going to turn to the treatment side effects. Steroids are very often used in the multicentric form of the disease to dampen down this inflammatory response and to make patients feel better, to turn off the night sweats, the fevers, the weight loss. The problem with the steroids, again, they have to be given in high doses, and when you wean patients off, the disease can flare up. The side effects of steroids are really well fairly well known. Steroids can cause weight gain. It can also change your body appearance. You can get more fat deposition. Your face can look full, a so-called moon face. And the alteration in appearance can be particularly hard for female patients because there's so much stress, so much emphasis in society for females to look good. Then quite often the steroids can make you feel irritable as well when you take it. So on the day that you take it, you get a lot of energy, and the day after, if you take it intermittently, patients can feel tired and unwell. Steroids can also raise your blood sugar. And if you have a tendency to get diabetes, you may need some treatment for the high blood sugar. This can either be with tablets, but sometimes patients need insulin. Then in terms of other side effects, patients can get swelling of their legs. We call it edema. This can be managed with diuretics, water pills to get rid of the edema. And the stomach can get irritated with the steroids. So a patient can get heartburn and indigestion. So usually it's quite difficult to give steroids going long term, except for small doses. Another treatment which is commonly used is called rituximab. Rituximab has been around since the 1990s. It's a very well tried and tested drug. We know the side effects. It kills or tries to eliminate some of the cells, some of the lymphocytes in the lymph nodes. It shrinks the lymph nodes. The problem is that it doesn't discriminate between the normal cells and some of the cells which are there as a result of the inflammation. So it knocks out the cells which produce antibodies. So your normal antibody levels can be low, and you can be open to infection. So one of the things that one can do is try to vaccinate. There's a pneumovax vaccine, another similar vaccine called Prevnar 13, which is useful to consider. If patients have repeated infections, you can actually give antibodies, and you can infuse them monthly. That's called IVIG treatment. So you can replenish the antibody, the normal antibody pool. Then infusion reactions occur sometimes with the first dose. These are fevers and chills. Pre-medications can be given to prevent it, and usually just slowing the rate down calms down the infusion reaction. The infusion reaction again is mostly with first dose. One patient has received 1 or 2 doses. Infusion reactions are rare. I should also say that about the steroids, there are ways to manage the steroid side effects. Obviously, in terms of weight gain, you want to watch your diet and see be careful what you use in terms of sugar intake. There are ways to deal with the irritability. Sometimes patients take the steroids first thing in the morning, and they get the side effects late in the day. Some other patients like to take it at night and find that they get their side effects and the irritability maybe a little earlier on, and they feel that they sleep through it. Again, if you have a lot of edema, you can get diuretics, which remove the fluid. And very often prophylactic medication is given, which cuts out acid secretion in the stomach to prevent stomach irritation. Then the anti-IL-6 antibodies, the ciltuximab and the tocilizumab, or the brand names are Sylvant and Actemra, they have very similar side effects. Just like the rituximab, you can get fevers and chills with the first dose. Again, pre-medications can help, giving it slower can help. The antibodies can raise your cholesterol. So to have once or twice a year your cholesterol tested is useful, and some patients need an anti-lipid drug. The liver function test can be abnormal at times. The way to deal with that is to delay a dose by a couple of weeks, and usually these abnormal liver tests are transient and they're not a serious problem. The blood platelets can also be low as a result of the anti-IL-6 antibody treatments. The platelets are little cells in your blood which help with blood clotting. Usually the platelet count doesn't go low enough to cause any problems. So it's more something that the doctor sees rather than that it causes a real problem. When you use these anti-IL-6 antibodies alone, without any other drugs, you usually do not see any problems with infection. When you combine it with steroids or other medications, then there is probably an increased risk of infections. And things like shingles, for which you can take prophylactic drugs like acyclovir, that's antiviral drugs. So in general terms, these antibodies are actually very well tolerated. I've got one patient who's been on the Sylvan drug since 2005, and a couple of patients who've been on Actemra since 2002. Then some patients need to receive what I would call real chemotherapy. That's the chemotherapy that you give for lymphoma, or alternatively for another blood cancer called myeloma. And that's chemotherapy which is usually given over around 4 days. Patients can lose their hair. Sometimes during administration there can be nausea, vomiting, and the chemotherapy will make your blood counts low, at least temporarily. Then your blood counts recover again, and then you're ready for the next cycle. Usually these chemotherapies are given on a monthly basis for a number of cycles. Then the chemotherapy also can cause irritation of the lining of the mouth and the guts. We call that mucositis. And sometimes people don't feel well. They complain about a lack of energy and malaise. Also, an important thing, if you have side effects and symptoms, is to try to figure out with your doctor what is actually due to the treatment and what is caused by the Castleman's disease. And usually the answer is in trying to figure out how well the Castleman's disease is controlled. The management of symptoms is very important. And when you go see a doctor and you have symptoms, make a little list of your symptoms and go through them. And again, sometimes you need to try and work out what is caused by the Castleman's disease or what is caused by the symptoms. There is very good prophylactic medication that can be given to deal with the side effects of all these treatments. There's anti-nausea medication, anti-diarrhea medications, there are antivirals, antibiotics. There's this antibody preparation that you can infuse to IVIG. There are medications to prevent irritation of the stomach, medications to prevent infusion reactions. So there's a whole array of measures that one can do to prevent side effects. So mostly one tries to prevent rather than to have to deal with the actual side effects. I think there is another aspect to Castleman's disease which is very often sort of ignored in the medical literature. Dealing with a disease and requiring long-term or intermittent treatment really changes your look on life, and it creates a lot of anxiety and raises a lot of questions. You know, can I be able to work? Will I ever feel normal again? There's stress about the future. How long do you need treatment? And quite often patients have sleep disturbance, and they just don't seem to be able to get going again and to get back to normal. It's almost like there is a type of post-traumatic stress disorder due to the battle with Castleman's disease. So dealing with all these issues of anxiety and worries is actually very important. We're all animals who live by routine, and usually people function better if you get a good routine going. It's important to maintain a good sleeper rhythm, so don't take too many naps during the day, but make sure you get your sleep at night, because otherwise you find that you get a fragmented sleep. You get a couple of hours sleep at night, and then you have to take naps during the day, and you never feel quite right. There are other things that you can do. I think you need to maintain a healthy diet, take a multivitamin, and do whatever exercise you can do. Exercise makes you feel better. Your brain makes something called endorphins when you do exercise, and they make you feel good. Sometimes exercise is difficult because of other medical conditions, and I usually advise patients to do what they can, whether it's stationary bike, water aerobics, or just walking on a regular basis. Then if you have problems and you're worried, I think it's very important to seek help. Sometimes speaking to other patients can help. Also, if you have a good friend you can rely upon, or sometimes something from the outside can help, like a pastor, etc. I'm a great believer in also in some of the alternative therapies. It's very important that you can learn to relax. If you have symptoms, you can get in the habit of listening to them. We all know that if you have a sore back, that if you're busy during the day, we don't notice it as much. But if you go to sleep, you don't have anything else going on, and you lie in bed in a dark room, and you notice symptoms more. So you can actually learn to relax and pay less attention to the symptoms. So it's important to be aware that you have some active control over all of this. Turning from transformation from unicentric to multicentric disease, I think that is extremely rare, if at all. So if you have unicentric disease, it will remain unicentric disease. If you have multicentric disease, then it will remain multicentric disease. Again, unicentric disease means disease in one side, like in the neck or in the armpits. And usually with the multicentric disease, you have it more generalized, that is in all the lymph node areas. Now, in medicine, not everything is black and white. We like to think that patients either has unicentric disease or multicentric disease, but there are also some patients which we call more regional or oligocentric disease. That means, for instance, they have disease in the neck and the armpits, or they have disease in the groins and in the lower part of the abdomen, lower part of the belly. So not everything is black and white. So there are patients who have got more than one lymph node station involved, but there are not multiple areas involved. And this behaves more like unicentric Castleman disease rather than multicentric Castleman disease. Now, what about transformation to cancer? First thing to say is that if the disease is adequately treated, then there will not be transformation to a cancer. That is unlikely. There is a low but definite risk of the multicentric disease transforming into a lymphoma. But again, if you do treatment, then this usually does not happen. Now, the unicentric disease can rarely transform into a very rare tumor. It's called follicular dendritic cell sarcoma. This is an extremely rare disease, and I think Just the patients and the doctor need to be aware of it. But again, the transformation to this type of cancer is very rare. So in general terms, you don't need to worry that if you have unicentric disease, that you're going to get multicentric disease. And also the risk of both unicentric and multicentric disease turning into a cancer is very rare. One of the questions which was put to me was pregnancy. So can I get pregnant when I have Castleman's disease? So what are the effects of multicentric and unicentric Castleman's disease on pregnancy? You can imagine that if you have multicentric disease and you have night sweats, fevers, and you're not feeling well, and you're not eating properly, and you're losing weight, that may have adverse effects on a growing child in the belly as well. Furthermore, if you have unicentric disease and you have a big mass in the pelvis or in the abdomen, it will be difficult for the womb to expand and accommodate a growing child. So in general terms, management of Castleman's disease in pregnancy focuses on the mother. And that's a golden rule for all medical diseases. If you make the mother better, then the pregnancy will proceed as normal. With unicentric disease, if there's disease in the pelvis or in the belly, you can resect it. And for the multicentric disease, treating the mother appropriately is important. Now, can the pregnancy affect the Castleman's disease? That's a question that we know very little about. In general terms, pregnancy suppresses the immune system. And that's actually very logical when you think about it. Because pregnant women really have a child growing in their womb is a completely different genetic makeup. And the pregnancy suppresses the immune system so that you literally don't reject your own child. So some of you may have heard that pregnant women are more at risk when they get flu. And sometimes pregnant women can die of influenza. And that's for the very reason that pregnancy suppresses the function of the immune system. Now, with multicentric disease, one would think that suppressing the immune system may actually be beneficial. Unicentric disease, one would anticipate that there would not be much effect. But in reality, there is very little data on the effects of pregnancy on Castleman's disease. And these are mostly educated guesses. Probably the most important thing is to try and plan your pregnancy. If your multicentric disease is well controlled and has been in remission for several years, you probably, if you're on the anti-IL-6 antibodies, you probably could come off treatment for a while and have a baby. Because usually the disease does not relapse immediately. So that's something you could discuss with your doctor. Again, having the disease well controlled prior to pregnancy is important because some of the drugs we use can affect a pregnancy. Steroids, for instance, can cause early maturation of the lungs in the child. The antibody therapies do cross over to the child. So for instance, the rituximab would have an effect on the forming immune system in the fetus. Having said that, rituximab has been used for patients with autoimmune disorders who get pregnant, and women have had normal babies. The effects of the interleukin-6 antibodies on pregnancy is essentially not known. One would think there would be little effect, but this is not known for certain. Chemotherapy, real chemotherapy, stuff that makes your hair fall out, can affect especially the growing child in the first trimester of pregnancy. And one should not have chemotherapy for sure in the first trimester of pregnancy if you can avoid it at all. Sometimes women have been diagnosed with lymphoma later on in the pregnancy, and women have been treated for lymphoma and have had successful pregnancies. However, in general terms, one obviously, if at all possible, would like to avoid chemotherapy drugs in pregnancy. So planning is important if you can. But Castleman disease per se is not incompatible with having a child. So maybe we have a little time for questions and answers after all of this. I think it's important to not be afraid of your disease. You do have an element of control. You can select or seek advice from a doctor who knows something about the disease. And it's very important to connect with the Castleman's disease community to get good information about the disease, about the treatments, about their side effects, and to know what to expect. And it's very important to realize that the vast majority of patients are not going to die of this disease. They may need treatment, but for most patients, the future is good. So I think it's important to be in charge of your own destiny. Be your own Castleman warrior and be active in the management of your disease. And support the CDCN so that we can find better treatments. And I'm going to give it back to David for any questions.
Thanks so much, Frits. That was really, really great. And just for the folks on the line, those questions that Frits was answering and gave us so much detail on, those were questions that have been posted in the ICDO Facebook group, in the Castleman disease support groups, Rare Connect. So those were questions that have come up most frequently online, and we've been watching them and sharing them with SAB members and wanted to make sure that we answer them to the best of our abilities, and Frits certainly did. So I do think we have a little bit of time for some questions for Frits, and just before I open it up for that, I did also just want to highlight that just as Frits said, particularly as he talked about pregnancy and treatments, there are so many things that are not known about the disease because so little research has been done, and really the Accelerate Registry is probably our best bet at getting that kind of information. So if we find out about patients who have been able to successfully get pregnant and we can get that into the registry, that's really helpful for us better understanding the disease. But I think we've got about 10 minutes or so if anyone wants to ask questions. Frits, maybe I'll kick it off with a question for you. Just in case there are any MCD patients on the call that were interested to know about the difference between HHV8 positive MCD and HHV8 negative MCD, and if they should seek a different kind of doctor and or potentially different treatments based on whether they have that virus.
Yeah, I think the treatment is quite different for HHV8 positive disease. This is driven by a virus, and it goes into a certain type of cell which is called B lymphocytes. That's where and also some plasma cells, and these can be targeted with the antibody rituximab. So usually the treatment of choice is a rituximab-based treatment regimen. And the first port of call is not anti-interleukin-6 therapy or chemotherapy. Most doctors who have experience with this are doctors who treat infectious diseases. So the CDCN will be able to connect you with doctors who've got experience with this HHV8 type Castleman's disease. And again, it's driven by a virus, and it usually, historically, has landed with infectious disease doctors. So they usually have the most experience with managing this disease. David?
Yes, that's great. Thank you so much, Frits. And I see that there actually were a couple of questions that have come up through the messenger. So someone asked, the patient has idiopathic MCD, so that's HHV negative MCD, and they said, my lymph nodes continue to enlarge. What is going to happen as they get larger?
If lymph nodes continue to enlarge, they first of all, they can give rise to discomfort. Sometimes lymph nodes can press on an important structure, like a big blood vessel or a big nerve, or things like the ureter, which are the tubes which connect the kidney with the bladder, and can give rise to symptoms that way. Also, if the lymph nodes continue to enlarge, you may get more symptoms in terms of night sweats, fevers, and other abnormalities. So the way to deal with that, obviously, is to find the right treatment. If you have steadily enlarging lymph nodes, you're probably not getting the right treatment. Obviously, the way to determine that is by doing either CT scans or PET scans and follow your lymph nodes serially to really objectively determine whether there is an enlargement or not.
Great. And then, Dr. van Rhee, a couple more questions have just come in. So the first one is for IMCD, what are the chances of relapse? And I'll just mention really quickly, and want to hear Dr. van Rhee's as well. I think something that's really important for all of us with MCD to be aware of is that the disease is extraordinarily heterogeneous. So some patients can have multicentric Castleman disease where they're never hospitalized and they experience mild symptoms, and other patients experience very severe symptoms where they are hospitalized and they get very, very sick and relapse frequently. So I think the challenge we face around saying what chances are is that everyone seems to be a bit different. But again, data into the registry and to Accelerate helps us to understand what is it that makes some patients different than others. What else would you add for chances of relapse, Frits?
Well, we know from the data that we've gathered is that the chances of relapse are increased with if you only do as management prednisone or rituximab and steroids. You correctly pointed out that there are patients who do very well with the rituximab and steroids, but they have to be carefully identified. The response rate is higher with the anti-IL-6 antibodies, and patients who are probably a bit more sick and have a bit more night sweats, fevers, and weight loss, and lab abnormalities, they're the best candidates for the anti-IL-6 therapy. However, the problem with the anti-IL-6 therapy is that it's more or less ongoing. So if you stop the anti-IL-6 antibody, the patient will eventually relapse, although this may not occur immediately. So the downside is that it's ongoing therapy. And then the patients who really need chemotherapy. And I just looked at our data, and some patients who need this chemotherapy actually do well with that. But again, there is also a definite risk of relapse. Sometimes patients get multiple courses of chemotherapy, and their disease remains under control with that, but it obviously is not an ideal situation. This is, again, I cannot emphasize this enough. David very correctly pointed out that this is a heterogeneous disorder, and we need to understand more what is causing this, and that's why the research is so important, so that we can figure out which patient needs what treatment.
Absolutely. Thank you, Frits. So we've actually got a few more that just came in, so I don't know how many more we'll be able to fit in time-wise, but there's a question about can tocilizumab be used in HHV8 positive MCD?
In principle, yes. However, the viral interleukin-6 can sort of bypass the interleukin-6 receptor, and then we know about the effectiveness of the rituximab-based therapy. So the tocilizumab is really an unknown, how effective it is. There are reasons to suggest that it's not going to be a highly effective therapy. So the rituximab-based therapy is definitely the first port of call.
Yeah, absolutely. Tocilizumab is really more used for HHV8 negative MCD because, again, even though they're both called multicentric Castleman disease, they really are quite different disorders. There's a question here. Someone says their son has HHV8 negative idiopathic multicentric Castleman disease. They want to know, is the mortality rate still high? And they can't seem to find many patients with this subtype. I would say that I would say most of the people on this call actually are HHV8 negative multicentric Castleman disease. So it is certainly something that happens, and in particular, a group that just looking at the roster of people on this call, there are quite a few. As far as mortality rate, I think, again, I would emphasize just how heterogeneous, meaning how varying the outcomes are for patients that have Castleman disease, and how you really need to get to the right centers. There is data online about outcomes and mortality from the Mayo Clinic and from a few other places, but unfortunately, those data are not necessarily a great. They don't mean everything for every patient, and so I would really encourage you to talk to us in the CDCN about being an expert who has experience treating it, because patients will obviously do much better with more experienced physicians.
So the other thing, if I may say one thing, David, about the outcome data. These are quite often historical data which go back a long time, and I think awareness and how to treat Castleman's disease, even in the big centers, has improved enormously in recent years. So I don't think necessarily that historical outcome data represents what is going to happen to patients who are currently struggling with Castleman's disease.
Absolutely.
So I do think that we have a long way to go, and obviously we need to improve treatment. But I think through the CDCN and through learning about this disease, I think that the treatment is better than it was 5 or 10 years ago.
I agree with that, definitely. Okay, so then there's just a few more questions. I think we'll just go a couple minutes over. Frits, is that okay with you?
Yeah, sure.
Okay, just a couple more questions, and I think we'll get through everyone. So there's a question about, we talked about managing pregnancy for the female, but what about the effect on the male for fertility? And I think that, again, this gets into a question that just no research has ever been done. We do know that chemotherapy, if you get the what Frits referred to as the real chemotherapy, that absolutely does affect your fertility chances. However, there's very little known about these other treatments and the effect they'll have. So again, I'd mention the registry, because the more patients we can get in the registry that are on that experience this, the more data we'll have. Okay.
Yeah, I think the other thing I would like to add is that obviously chemotherapy for sperm is not good. But however, if you're taking a drug like rituximab or siltuximab, the effects are not known. But if you would guess, they're not going to be adverse. And you can always have the male sperm examined by an expert. And that can give you some reassurance whether the sperm looks normal and moves normal and is likely to function normally.
Absolutely. And that's really important, that if you have these questions, to talk to a reproductive endocrinologist or OBGYN. And unfortunately, they won't have study data to they won't have study data to demonstrate whether the outcomes to expect, because no one's done the research before. But hopefully, with more time and more patients in the registry, we'll be able to have more information about that. The next person asked, they said that they have IMCD, they're feeling good, normal CRP, normal VEGF. Is it okay to not be on any treatment? And the quick answer to that, again, is everyone's is quite different. But it's certainly, if you're tracked and you have a physician who's experienced treating Castleman disease, it's something you could consider. Frits, what would you say?
I think one thing you could do if you're on the anti-IL-6 therapy, very often it's possible to space out the doses of treatment. So people could go to 3 or 6 weekly dosing. I've even got some patients on 3 monthly dosing. So it's definitely possible to delay it, to lengthen the intervals between the doses.
Absolutely. It makes a lot of sense. So the next question was, I've been on Sylvant for 4 years and my lymph nodes continue to grow. Should I be looking at different treatment? And I would just mention here that we know that Sylvant or siltuximab works very, very well in about a third to 1/2 of patients with HHV8 negative MCD, but we also know that there's about half of patients where the drug's just not going to work for them. And so you have to have a physician who is able to assess, are you in that group that the drug works really, really well, or are you the group where it doesn't? And then be able to use that information to determine whether it makes sense to continue on therapy. Frits, what else would you add?
No, I completely agree with that. It may be that patient in question would do better with the rituximab treatment, for instance.
Absolutely.
But again, if you have a situation like that, you may want to make sure that you're seeing somebody with experience with these drugs and disease. I think that's very important.
I agree. And then this is the last question. It is, well, first I'll just speak to this one, is that yes, we are going to make these slides available. We'll put something up online with this webinar. But then the question is, how are folks using sirolimus doing? So I'm aware of about 10 patients that have been given sirolimus thus far, and I'm aware of a little bit under half of those patients that have improved with the drug. So it's helped for some, but it certainly is not the miracle drug for everyone. I'm personally on sirolimus, and I've been doing well for remission, but unfortunately, as I said, it's been given to some patients that were quite sick in the hospital, and it did not induce a response in those patients in the hospital, but we have seen it help patients who are out of the hospital. But again, this is why additional research is needed, and why we need to continue to enroll patients into Accelerate and continue to get blood samples whenever possible.
And then maybe we also hope to do a study with the sirolimus drug.
Exactly, and hopefully in early 2019, we'll be in a position to enroll patients into that study to be able to understand, is this drug something that's going to be helpful for a lot of other Castleman disease patients moving forward, and what's the kind of patient it's most helpful for. Great. Well, I think that gets through all the questions. Thank you all for staying on afterwards. I think we had what I thought was a wonderful, wonderful discussion and talk from Dr. Van Rhee, and I just so appreciate all the great questions and interaction. There actually was a question that just came from Holly Hutzer, and what I'll do is I'll have Frits and I get back to you, Holly, just since we're already over the 11 o'clock time with the answer. But thank you guys so much for your time. Does anyone have any last questions? Or actually, we really don't have time. But we'll follow up with Holly, Frits, and thank you so much for your time and everyone for calling in.
All right. Thank you all.
Thank you.
Thank you.
David? David?
Yes, Frits, can you hear me?
So, you know that we got the results back of the blood paper.
I saw that. Great news. I haven't gotten back to you right away, but it looked like that was a really positive review.
So, I mean, there's nothing there which cannot be addressed. So that's good.
I was so excited to see that. That really is awesome news. Congratulations. That's great. I know that was it's a lot of work, so I'm really happy about that.
The other quick thing is, do you have an agenda yet for the patient meeting on the 21st of September?
We do. Curran has put together an agenda, and so we can make sure that gets sent to you. Curran should be able to hear right now, so we can get that the agenda sent to you.
So I think I need to catch a flight at 5:45 to the airport. That's the only thing I need to say.
Oh, sorry. Say that again, Frits.
I need to catch a flight at 5:45, so don't put me on late in the afternoon.
Okay. Yeah, we'll make sure that that's not the case, that you get in early enough.
All right.
The agenda now.
And
Okay,
then
thank
for
you.
the one question that came up after after we ran out of time was a patient saying that lymph node was removed 6 years ago, but she continues to have symptoms of severe weakness and night sweats. This is a UCD patient. And then is this common once a lymph node is removed to have continued weakness and night sweats after UCD is taken out?
Yeah. I think that usually cannot be due to the Castleman's disease, the night sweats at least, isn't it?
Yeah.
I think some patients have difficulty coping with the disease and adjusting psychologically. And I think that's a real issue. I think it's not patients being complainers or I think it's a real issue.
Yeah, and I think that's exactly right. And the one thing I will also mention to her is that it's possible that that maybe the lymph node was not completely resected, and maybe there is still some potential some potential benefit that could come from seeing if there's any remaining lymph node.
Yeah. And obviously, if usually the night sweats and whatever, she should have a normal lapse.
Yeah.
Yeah. It's very interesting that you see that so much in Castleman's disease. You just wonder whether the patients who make things like IL-6 or other cytokines, whether it has an effect on the central nervous system, and whether these effects time to revert. I think we don't know too much about that.
Yeah, absolutely. Great. Well, thank you so much, Chris. I think it was so great to have you lead this, and I know that the patients really benefited from it. Sorry about all the technical difficulties. I'm not really sure why. We've been using Join.me for years and never had issues like this. So what we'll do is we'll edit the video and audio. Do you feel comfortable with us if we edit it to kind of get rid of the technical difficulties, but then to make this available online?
No, absolutely. Go ahead.
Okay, great. So we'll edit it just to cut out like the times where we were trying to figure out audio and stuff like that, and then we'll post something that's that you can watch.
Okay. Thank you.
Great. Well, thanks so much, Fritz. And Katie, thanks so much. Have a great rest of your day, guys. And keep you posted about the blood article. That's awesome news.
Yeah, okay. I will. Thank you.
All right, thanks, guys.
Bye-bye.